Acid-base disorders are extremely important for surgeons to identify certain problems which affect the patient's condition and also give us an idea where the patient's condition is deteriorating. And when patients come with the emergency, either due to trauma or peritonitis or severe pancreatitis, you have to use acid-base balance and also ischemic bowel. You have to use acid-base balance to identify the problem. And then when patients have been operated in the post-operative status, if there is any deterioration, acid-base balance again plays an extremely important role to monitor the patient in terms of their improvement or deterioration. So with that in mind, Nikitha is going to talk about the acid-base disorders and then what implications they have for surgeons. Okay, over to you, Nikitha.
Thank you, sir. Good evening, everyone. Today's topic for subject seminar is acid-base disorders, being moderated by Dr. H.R. Ravishankar. So first we'll be seeing about acids and bases in our system, and then the primary investigation, ABG, and how to interpret it, the outline of disorders caused by the acid-base disturbances, and surgical aspect of these disorders and their management. There is an extracellular and intracellular chemical buffer system which is mainly maintained by respiratory and renal regulatory mechanisms in our body. Most important things are carbonic acid, which is a weak acid, and bicarbonate, weak base, which are in the ratio of 20:1, 20 being bicarbonate and 1 being carbonic acid. This is our primary buffer system. Carbonic acid is generally represented by carbon dioxide in the arterial blood, and bicarbonate is maintained by renal regulatory mechanisms. pH, whenever we say pH generally represents the negative log of H plus ion concentration in arterial blood, and the normal range is 7.36 to 7.44. This equation summarizes the acid-base balance in our body. So whenever there is a disturbance, compensatory mechanism occurs and the balance is maintained. But in case of incomplete compensation, pH will be detected to be abnormal. So that results in acid-base imbalance. Most common are the simple acid-base disorders, but in complicated scenarios, this can give rise to mixed acid-base disturbances. So how do we measure the acid-base disorder or disturbance, and how to know that what is out of balance? In order to measure that, we need to know how do we generally measure acids and bases. Carbonic acid, which is represented by partial pressure of carbon dioxide, it's generally measured in mm per Hg, mm of Hg, and the normal value is 31 to 42. Bicarbonate is measured in millimoles per liter. Its normal value is 22 to 25. And the other components of ABG, partial pressure of oxygen, 80 to 110 millimeters of Hg, and base deficit or excess is in general plus 0.25. So let's get to the terms which are generally used: acidemia, alkalemia, acidosis, alkalosis. Can anyone tell me the difference between acidemia and acidosis?
Who's Ajay? Ajay? There's somebody called Ajay here in the thing. Please identify yourself and can you please tell us the difference between acidemia and acidosis? Apurva? Okay, Praveen, do you want to take that question?
Sir, exactly, I don't know, sir.
Apurva? Okay. Nikita, I
Yes.
think you'll have to tell it.
Okay. So acidemia generally represents the state in which there is an increased acid production, whereas acidosis is the process which is leading to acidemia. So it's just a
Say it again.
yes, acidemia is a state, sir. It's a state in which the acid production is high, whereas acidosis is a process. So by acidosis, a person lands up in acidemia.
Okay.
Yes, sir. So a very experienced intensivist might pick up on few clinical signs, but for young amateurs like us, in order to find out what disorder a patient has, what kind of imbalance he's in right now, we must be able to read an ABG. So let's understand how to read an ABG. I would like to emphasize on rapid interpretation of ABG. This is called Henderson equation. So whenever we get an ABG report, by looking at it to identify whether it is reliable or not reliable, we can just use this equation. If the above mentioned values, when we substitute and we get a 24 as an answer, this shows that the ABG is reliable and we can use it to identify whatever is going on with the patient. And to use in the equation, the hydrogen ion is calculated by subtracting two digits after the decimal point of pH from 80. And we have to turn to the patient after seeing ABG to obtain a relevant clinical history. Without seeing the patient, by only looking at the ABG, we cannot interpret a proper disorder or imbalance. So, and next we need to know the oxygenation status of the patient, which is generally judged by the partial pressure of oxygen. However, without knowing the clinical situation, whether the patient is on ventilator or whether patient is on oxygen supplementation, and the level of oxygen he is taking right now, we shouldn't be jumping into the conclusions of acid-based disorders. And we need to identify the primary disorder by looking at the pH. So whenever there is low pH, that indicates acidosis, and whenever there is high pH, that indicates alkalosis. So after looking at the pH, then the second thing we have to do is look at the partial pressure of carbon dioxide. So this represents, this is a respiratory acid, and this explains the change of pH, then it is a respiratory disorder. Otherwise, we have to look at the bicarbonate level. So in a normal ABG, pH and partial pressure of carbon dioxide move in opposite directions. So as the partial pressure of carbon dioxide increases, pH decreases. That means patient lands up in acidosis. So bicarbonate and partial pressure of carbon dioxide move in same direction. If the trend of change in partial pressure of carbon dioxide and bicarbonate are in same, then we have to check the percentage of difference. So the one with a greater percentage of difference between the two is the one which should be considered as a dominant disorder. We can also find out whether that is acute or a chronic disorder by looking at the rate of change of H plus ion concentration to rate of change of partial pressure of carbon dioxide. If it is greater than 0.8, it is an acute presentation, and if it is between 0.3 to 0.8, it is acute on chronic presentation. So as we talked earlier, to maintain the balance of the acids and bases, their compensation always occurs. So how do we calculate, how do we assess the compensation? In case of respiratory acidosis, in acute settings, bicarbonate increases by 1 milli equivalent for every 10 mm Hg increase in partial pressure of carbon dioxide above 40. And in chronic settings, it increases by 3.5 milliequivalents. In case of alkalosis, bicarbonate decreases 2 milliequivalents for every 10 mm Hg decrease in partial pressure of carbon dioxide. And in chronic cases, it decreases by 5 milliequivalents for every 10 mm Hg increase in partial pressure of carbon dioxide. This can also be calculated by an equation. The compensated the lungs in the form of carbon dioxide excrete by carbonic acid, and kidneys retain bicarbonate. Partial pressure of carbon dioxide falls, and there will be a rise in pH. So the expected partial pressure of carbon dioxide is calculated by 1.5 into bicarbonate value plus 8 plus or minus 2. So this happens in case of compensated metabolic disorders. But in case of uncompensated disorders, there will be no change in partial pressure of carbon dioxide with the change of bicarbonate. One of the important point in acidosis is anion gap. Anion gap, it is represented it represents the unmeasured anions in our system. Those are generally anionic protein such as albumin and phosphates, sulfates, and organic anions. Organic anions are mostly lactate and acetoacetate. So in situations such as lactic acidosis and diabetic ketoacidosis, there will be a high anion gap metabolic acidosis. And in case of mixed disorders, if the pH is normal and ABG may be normal, or it could be a mixed disorder. So in those cases, we have to calculate the difference in change of bicarbonate and change of partial pressure of carbon dioxide to see which is a dominant disorder. Whichever has the highest change in the difference is the dominant disorder.
Go back, ma.
Yes, sir.
Praveen, did you understand that?
Yes, sir.
Huh?
Yes, sir. Yes, sir.
What is a mixed disorder then?
Sir, here, to explain. Sir, here both there will be increase, sir. But the part of which is increasing will be considered as dominant, sir.
Which is
Whether
both?
if it
What
is,
do you mean? What do
sir,
you mean?
if carbon dioxide and bicarbonate can be increasing at the same level, sir. But the which one, whether the bicarbonate or the carbon dioxide, which is there is difference from the normal value, which is greater, it will be considered as dominant one, sir.
No. I don't think you understood. See, what is a mixed disorder?
There may be
Sometimes,
both.
for example, in very severe sepsis,
Yes,
you
sir.
can have renal deterioration and also respiratory deterioration. So you
Yes,
can
sir.
have both a respiratory and combined respiratory and metabolic acidosis. So in
Yes,
that
sir.
case, you have to measure the partial pressure of carbon dioxide and also measure the bicarbonate in the
Bicarbonate.
blood gas.
Yes,
So
sir.
if the difference, for example, the bicarbonate, Nikitha, what do you mean by this difference? Is it previous value to current value or what?
Yes, sir. Previous value to current value, sir. The difference between the two ABGs.
So, Praveen, do you understand what I'm saying?
Yes, sir. Yes, sir. Understood, sir.
So, patient,
Which
for
are difference?
example, came with trauma or acute pancreatitis or severe sepsis, or even for that matter, bowel ischemia and and predominant metabolic acidosis, because the abdomen is distended, the diaphragm is stented and is not able to breathe, and because abdomen is distended, the blood, the venous return is decreased. So all of these combined mechanisms, there may be metabolic acidosis and also combined respiratory acidosis. So if you check the partial pressure of carbon dioxide in the first blood gas and then second blood gas, and then if you look at that, and then you get difference in the bicarbonate and carbon dioxide, if the bicarbonate difference is higher, that means it is more of a
Metabolic, sir.
metabolic acidosis. If the
Sir.
carbon dioxide difference is higher, then it's more of a
Of
respiratory acidosis.
respiratory acidosis, sir.
That is this one. That is what you should.
Yes,
So
yes, sir.
you have to look at the compensation. See, the thing is, most of the time, if there is severe metabolic acidosis, there is respiratory compensation by increasing the breathing. So what happens is, when there is severe acidosis, the body will breathe more rapidly, and then you excrete the carbon dioxide in the form of this one. The carbonic acid gets converted to carbon dioxide, and then it excretes it. And even the kidney also does what is called as aciduria. There will be conservation of bicarbonate in the convoluted tubules, and excretion of acid is usually the acid is conserved as opposed to bicarbonate. But when there is a severe acidosis, the reverse happens. So the bicarbonate is conserved and acid is excreted, and there is aciduria. But on the other hand, there is a condition called gastric outlet obstruction, where there is severe what? What happens in gastric outlet obstruction, man? Abdul? Or is Sania there?
Sir, in gastric outlet obstruction, there is a lot of loss of chloride and sodium. So there is a hypochloremic metabolic acidosis, metabolic alkalosis with paradoxical aciduria.
Correct. So there is hypochloremic, hypokalemic and hypochloremic metabolic alkalosis with paradoxic aciduria. Why is there paradoxic aciduria?
So it compensates to prevent loss of bicarbonate. The acid is thrown out in the urine.
Praveen?
Sir, normally for metabolic composition will be by the respiratory, sir. But here kidneys also functioning to compensate, sir. So that's why paradoxical aciduria, sir.
You need to read up and put it up in the group. Okay?
Yes, sir.
I want the proper explanation.
Okay, sir.
Okay.
Yes, sir.
Right. Any doubt so far?
No, sir.
All of you need to go through what is called the Henderson-Hasselbalch equation for acid-base balance. Okay.
Sir, I would like to emphasize on one point, sir. Mixed disorder generally represents like two independently existing disorders, sir. Like here mentioning about respiratory acidosis and metabolic acidosis in a same patient. So he'll be having like diabetic ketoacidosis along with respiratory acidosis for some
Patient
other
may have
reason.
COPD. Patient may have COPD and diabetes, and then they may develop diabetic ketoacidosis. Or patient may have COPD and then they develop peritonitis and metabolic acidosis. Or pancreatitis and metabolic acidosis. Yeah. That's understood. So pre-existing condition, and if the patient has renal failure and then they develop respiratory problem, they can have both metabolic acidosis, and on top of it, you can have respiratory alkalosis. So all sorts of things can happen.
So can a patient have two opposite disorders also, sir?
Yeah, they can.
Respiratory acidosis and metabolic alkalosis.
They can.
Okay.
Depending on
but how can we differentiate it being a normal compensatory mechanism to a independent disorder, sir? Is there any
That is why acid, interpretation of blood gases, as you said, is clinical. So you have to look at the clinical picture and see what is the problem, and then look at the blood gas, and then you can say, is it just compensation or they are two different disorders occurring in unison.
Okay.
Okay.
Yes.
Right. Any questions? Any doubts? Okay, carry on, ma. So I think go back to the blood gas interpretation. So blood gas interpretation, the things that you look for is, the first thing you look for is the pH value. So normally the pH is generally a little bit alkalotic. Why? Why can it not be acidic? Normally 7.35 to 7.44, no?
Yes, sir.
So it is generally a bit alkalotic rather than acidic. Normally the alkalotic pH will go to 7.5, 7.55 maximum. But acidic pH can go down to 6.8 and all that, which is incompatible with life. So why is the pH generally alkalotic rather than acidic? Anybody? Sania?
I'm not sure, sir. I knew it is alkalotic, but never thought why.
See, the two things. One is all the chemical reactions in the body are better if the pH is slightly alkaline rather than acidic. So that is one. And second thing is the normal oxygen, combination with the hemoglobin and its dissociation curve is very closely linked to it being slightly alkalotic. So that is why it is better. It is understood that the pH is generally slightly alkalotic rather than acidic. So
Okay,
the
sir.
oxygen dissociation curve and everything works because of the fact that it is slightly alkalotic. Okay.
Yes.
Okay. So the first thing is the pH. So you look at the pH and see what the pH is. Is it acid? Is the lower values means acidosis, higher values means alkalosis. Then you look at the partial pressure of carbon dioxide, which is very critical, and look at the partial pressure of oxygen. So that again will give you a hint whether it is respiratory or metabolic. Then you look at the bicarbonate values. Then you look at the base excess. So all of these you have to interpret all of them in conjunction, and also, as I said, clinical, look at the clinical status of the patient, and then you are able to interpret. If, for example, you know that the patient has already got COPD or something, then your interpretation will be different compared to if the patient is otherwise a healthy, normal individual. So that is the thing. So the pH, partial pressure of carbon dioxide, partial pressure of oxygen, and then bicarbonate value, then the base excess. Then we also get nowadays we get the lactic acid values also. So that is again a very good indicator of the status of the patient. See, there is a very good statement. See, the lactic acid is thought to be a cause of the problem, but it is only an indicator of the problem. So, they liken it to the presence of firefighters in fire. When there is fire, you have obviously firefighters. So that doesn't mean to say the firefighters are dangerous or the firefighters cause the fire. Are you following the interpretation?
Yes, sir.
So
Yes, sir.
lactic acid is there. It is actually it just indicates that there is a problem. And probably it is also to some extent trying to correct the problem. So lactic acid is not dangerous. It's not, doesn't, of course, if it is high, that indicates that condition is serious of the patient. But that is not the cause of the problem. You understand, no? Just like firefighters are there to fight the fire. They are not causing the fire. Okay, so lactic acid. So these are the components that you use to interpret the blood gas. Then obviously, if the pH is low, you interpret it as metabolic acidosis. But then if the pH is not so low, because the carbon dioxide is doing the compensation, then you have to say it is a respiratory compensation of metabolic acidosis. Similarly, if there is alkalosis and then the bicarbonate is compensating, then you then say metabolic compensation of respiratory alkalosis, because or respiratory acidosis, whichever the case may be. So you have to interpret this one, the acid base, the blood gases based on all these values, and then the clinical interpretation. So which clinical interpretation is, for example, if the patient has renal failure, then you expect certain changes. If the patient has type 1 or type 2 respiratory failure, then you expect certain changes. Then if the patient has diabetes, then you look at the urine and there is ketosis, then you say it is diabetic ketosis. Then you interpret it in a certain way. So it is blood gas is a part of the interpretation, not the sole interpretation. Okay, carry on, ma.
Yes. So we'll start with the disorders now. Let's start with metabolic acidosis. It can occur because of an increased endogenous acid production in the case of lactic acidosis and ketoacidosis, or loss of bicarbonate as in the case of diarrhea, or reduced H plus acidic excretion in case of renal failure. The surgical aspect, the most commonly we come across in case of release of clamped aorta during surgical treatment of aneurysm, and in case of sustained diarrhea, ulcerative colitis, gastrocolic fistula, high intestinal fistula, prolonged intestinal aspiration, and perioperative tissue hypoxia. These are the cases which will result in metabolic acidosis. And clinical picture, patient will be in rapid, deep, noisy breathing, which is termed as cusumal respiration. Here you can see the graph which is plotted showing depth of breathing and time. In comparison to the normal graph, the depth of breathing increases in cusumal breathing. And treatment for metabolic acidosis, generally we don't consider transfusing alkali unless and until we are sure that patient is in severe acidemia and there is no potential for bicarbonate in the plasma. And in that case, the desired bicarbonate will be calculated with respect to partial pressure of carbon dioxide, and the amount of sodium bicarbonate which is required to replenish the value is calculated using the formula desired bicarbonate minus absorbed bicarbonate into 0.4 into body weight, and it is transfused to the patient within the first 24 hours.
Just a minute.
Yes, sir.
Praveen, when do you consider giving sodium bicarbonate as a quick bolus? Anybody? If you have done again, I think Abdul, because he's done the ATLS recently, he'll be able to tell us. But Praveen, do you know when do you give sodium bicarbonate as bolus?
No, sir.
In shock, sir?
Bolus.
No, in shock, you give it as, you don't give it as quick bolus. You give it, you definitely infuse it in shock. But when do you give it?
IV, sir.
Huh?
Bupivacaine, when they are giving IV, intra-arterially they are given.
What? You know, I didn't follow. What did you say?
Sir, injection bupivacaine, generally they will give through IV, sir. By chance, if they give intra-arterial, they give bolus of bicarbonate.
I don't know about that, but that is a medical answer. But see, the main thing, but I don't know whether that is still true. In patients who have arrested and the patient is in severe metabolic acidosis and you are trying to resuscitate the patient, and what happens is when there is arrest, there is severe metabolic acidosis, which makes the heart resistant to the resuscitative measures and the treatment. So in those situations, you improve the acidosis by giving sodium bicarbonate as bolus, which is supposed to make the heart more, sensitive to other resuscitative measures. So that is when you give sodium bicarbonate. For example, you are doing CPR, you are giving adrenaline and everything, and if the patient is in fibrillation, you give lignocaine or amiodarone or whatever else we give, and then shock the patient and all of these measures, and still the heart is not responding. One of the things that they say is that if there is severe metabolic acidosis, the heart becomes resistant to your resuscitative measures. Then you give bicarbonate bolus and then continue the resuscitation to see whether there is any response. Abdul, what did they say in the ATLS, man?
Yes, sir. Mostly in ALS, sir, not in ALS. Sir.
ALS. Is it
Yes,
still the
they
teaching
are
or not?
different. It is there, sir.
It is still there?
Especially on necessitating patient in this.
Hello, I am not following. Your voice is breaking up.
Sir, it is still the choice, sir.
Okay, right.
Hello.
Yeah, I followed. Okay. Right, carry on, ma. Nikitha.
Yes, sir. Sir, out of all the surgical aspect, which of them is most common, sir, we come across?
See, the most common surgical thing which you have not mentioned here is this one. Sepsis, intestinal obstruction, and peritonitis, acute severe pancreatitis, trauma. Of course, this one, clamping of the aorta, that is part of what is called as the reperfusion syndrome. You can develop metabolic acidosis. So not just the clamping of the aorta, even the major, if you are doing embolectomy or you are doing, for acute limb ischemia, that can also cause reperfusion. And one of the things that can be seen is metabolic acidosis. Yes. But I think the common things, of course, gastrocolic and high intestinal fistula, that is surgical. And then severe metabolic acidosis that happens with sepsis due to peritonitis, anastomotic leaks, and then also acute severe pancreatitis, and also trauma. In patients who have trauma, you can develop, metabolic acidosis. Okay. So these are the things. For example, when you've done a major surgery and patient is not doing well, or when patient comes to you with intestinal ischemia, early signs before the white cell count goes up very high, the first thing that you see is metabolic acidosis with the lactic acidosis. So if you measure the blood gases and also lactic acid, then you will get an idea that you may be dealing with the patient with intestinal ischemia. Then patient who comes with severe sepsis, you are looking at the triad, which is the metabolic acidosis, coagulopathy, and hypothermia. Right?
Yes,
so
sir.
These are the three things which can kill the patient. So
Lethal.
you do damage control surgery. For example, if it's trauma, you open the abdomen and control the bleeding, because bleeding is one of the causes that will cause hypotension and acidosis and everything. So because it can also cause ischemia of the bowel, whatever, because if it is bleeding from one of the major arteries. So control the bleeding. And if the bowel is denatured, bowel is dead, you resect the bowel, but don't do the anastomosis. And if there is liver bleeding or splenic bleeding or renal bleeding, or usually retroperitoneal bleeding is one where you don't disturb the blood clots because it is naturally tamponading. The retroperitoneum would tamponade naturally, so don't disturb the hematoma in that area. Otherwise, rest of the abdomen, if it is trauma, look at the bleeding points and then control the bleeding. Liver, you do packing. If splenic injury, you don't usually open unless it is grade 4, grade 5 splenic injury, or if there is indication of associated injuries to either the duodenum or any other intestine or things like that, or pancreas. So basically you manage these things, you control the bleeding. If there is bowel, that is dead, or in case of peritonitis, you open the abdomen, thorough lavage and drain out all the pus, put proper drains in everywhere. And if there is bowel that is, either perforated or so, you resect that segment, don't do anastomosis. And then, you can either do a laparostomy and then take the patient back to the ICU, correct the hypothermia, correct metabolic acidosis, correct the coagulation disorders. And then 48, 72 hours later, you can do the definitive procedure. So these are the kind of, applied physiology, applied pathology of blood gas interpretation, especially patients with metabolic acidosis. So that is what we usually commonly encounter. Unless the patient in the post-operative phase has deep vein thrombosis, pulmonary embolism, then they have respiratory problems. So you will have to be conscious of that also. Okay,
Yes.
carry on. Any questions? Any doubts? Okay, carry on.
Yes, sir. The next one is metabolic alkalosis. It is the process. In this disorder, there is a primarily there is a rise in bicarbonate. It is either by extracellular fluid volume loss due to vomiting and diuretics, or excessive potassium loss with subsequent hyperaldosteronism. In general, metabolic alkalosis is often accompanied by hypochloremia and hypokalemia. Surgical aspect is mainly in case of chronic constipation and constipation disorders, intake of alkalis as a remedy, and repeated vomiting or aspiration, and pyloric stenosis. These are basic surgical aspects. And clinical picture, patient will be in Kind-Stokes breathing, and there could be presentation of tetany in few cases due to hypokalemia, due to hypocalcemia. Treatment, IV infusion of 0.9% saline solution for chloride responsive metabolic alkalosis. In some cases, acetazolamide is also used for the excretion of bicarbonate, and in resistant cases, hemofiltration or dialysis is an option, and electrolyte correction to be done. And hydrochloric acid in a very low concentration through central IV infusion is one of the considered option.
Hardly ever used.
Hardly ever. Yes, sir.
I think mainly fluid electrolyte balance. You have to correct the fluid electrolyte balance. And, the worst case scenario, you do dialysis. That is the best treatment. I've never seen hydrochloric acid being infused.
Yes.
But again, this is something you have to discuss with the intensivist and see, have they used it anytime? Because metabolic alkalosis is quite common condition. Okay.
Yes, sir. But majority of the cause for the metabolic alkalosis are renal origin, sir.
Yeah.
So yes, it's a very last resort using that. when the renal function is completely impaired, sir. Then comes respiratory acidosis. It can be due to severe pulmonary disease or respiratory muscle fatigue or abnormalities in ventilatory control, which result in increase in partial pressure of carbon dioxide and thus causes decrease in pH and respiratory acidosis. It is generally seen in reduced effective ventilation, like as I have mentioned, and drugs depressing the respiratory center.
Like
Surgical
what?
aspect, yes.
Like what? Which are the common drugs that can depress the respiratory center? That is why you have to be careful about these things. Praveen? Vinod?
Sir, benzodiazepines, sir. Midazolam diazepam.
Benzodiazepines and then?
And phenobarbital, sir.
No. You see, phenobarbital's okay, but what is more commonly given, man?
Opiates.
Morphine, pethidine.
Morphine.
So
Yes,
either
sir.
if the patient is a drug addict or if the patient you have inadvertently given them a lot of sedatives. So morphine and pethidine, they can cause, especially in patients who have either patients who are obese or patients who have asthma or respiratory chronic obstructive airway disease. In such patients, you have to be extremely careful giving morphine, pethidine, and opioid analgesics because that they can cause respiratory depression. And in patients who have had anesthesia and they are not come out fully of the anesthesia, they are still in patient respiratory paralysis, and patients who have pre-existing lung conditions, obesity, myasthenia gravis, and other musculoskeletal disorders.
Yes.
So you have to be careful in such patients. Okay, carry on, ma.
Yes, sir. Either airway obstruction or COPD disorders and the congenital disorders, and in cases of emphysema, pneumoconiosis, all the respiratory disorders. As sir mentioned, neuromuscular disorders like poliomyelitis, myasthenia gravis, and muscular dystrophies. The treatment is endotracheal intubation and or non-invasive positive pressure ventilation. Sodium bicarbonate is almost always contraindicated because of potential for paradoxical acidosis, except in case of severe bronchospasm, where it would help. Sir, in case of bronchospasm, how would bicarbonate help, sir? Like, is it like the respiratory system is unable to compensate, so we are going for the
No, I
bicarbonate?
think I don't know. I have seen them infuse bicarbonate through the endotracheal tube. So I think it probably maybe it will relieve the bronchospasm. You'll have to ask the anesthetist about that. I'm not entirely sure, but I have seen them give bicarbonate through the endotracheal tube. Anybody else has any idea? Sania? How will bicarbonate help in patients with paradoxical acidosis, in severe bronchospasm? Just find that out.
Yes, sir.
Carry on.
And oxygen administration, it should be titrated carefully in these patients because there could be chronic CO2 retention, and when oxygen is used injudiciously, the patients might experience progression into respiratory acidosis, and it should be avoided. Aggressive and rapid correction of hypercapnia should be avoided in these cases.
Because many of them, it is the hypoxic drive that is keeping their ventilation going.
Yes,
so
sir.
if you remove the hypoxic drive, they will stop breathing. You understand?
Yes, sir.
So that is why, as you said rightly, it has to be corrected slowly. Because many of these chronic obstructive airway disease, the system has got used to hypoxia, and it is the hypoxia that keeps their respiration driven. So if you take off the hypoxia, they will stop breathing. and then you will have to put them on ventilator, and the problem is then you will not be able to get them off the ventilator because they are comfortable. They will stop breathing anyway. So it is a very difficult conundrum. That is why you have to correct these things slowly.
Sir, and in chronic respiratory acidosis, it is very difficult to correct, sir, because as you said, they won't be responding well to it. The next one is respiratory alkalosis. This process that primarily causes reduction in partial pressure of carbon dioxide. There is due to increased ventilation. Example, in the case of response to hypoxia or secondary to a metabolic acidosis. In surgical aspect, it could be due to excess of pulmonary ventilation. And clinically, we can see the patient will be patient looks paler, and there is a fall in BP intraoperatively. The treatment in this condition is initially we have to correct the underlying disorder, and insufflation of carbon dioxide, rebreathing, and ventilator settings need to be changed in order to properly ventilate the patient.
So you ask them to breathe into a mask, and they keep rebreathing into that, so that carbon dioxide, levels go up. Okay.
Yes, sir. Can sir, respiratory alkalosis be present in a patient with a panic attack, sir?
Yeah, because they breathe rapidly, and there is carbon dioxide washout.
Okay.
So they can develop hypokalemia, and also what is called as they can develop this severe carpopedal spasm also.
Yes, sir. So in those cases, the primary disorder needs to be corrected.
Corrected.
But antidepressants and sedatives are not recommended for them. That's it, sir.
So any questions, any clarifications? What I would recommend is that you go back and read up, this chapter again, because I think whatever she is told, you feel you know everything, but then 2 days later, because these are complicated things and also very evanescent, so they just disappear, they just evaporate. So it is better to go back and study, so that it becomes a bit more steady and stable in your mind. So then you will be able to apply this. I think, as I said, the blood gases to be done judiciously in patients who are surgical. It will give you an idea. In addition, you should know the previous history of the patient, whether the patient has diabetes, patient has renal failure or renal sort of chronic kidney disease, and then patient has asthma or chronic obstructive airway disease or any other musculoskeletal problems. All these things make a huge difference in terms of your interpretation of the blood gases. And then you have to look at the clinical condition of the patient, whether the patient is in sepsis, hypotension, tachycardia, and oliguria, all of these things. And patient's condition will also dictate as to how you interpret the blood gases. And then you, depending on the history, the pre-existing medical conditions, and then the current patient's condition in total, then, and looking at the blood gases and lactic acid, then you are able to interpret what exactly is the problem. Is it a pure metabolic acidosis or pure metabolic acidosis with respiratory compensation, respiratory acidosis with metabolic compensation? So you will know all of these things, and then you will be able to tackle it accordingly. So that is the essence of this class. So it is a combination of previous patient past medical history, current clinical status, and then interpretation of the blood gas. And also you will probably have to do a chest x-ray, and obviously you have to know the patient's blood pressure and what oxygen setting is the patient on, Is a patient on ventilator or NIV, or is there just oxygen that you are giving? So all of these things together, you interpret the blood gases. So that is the essence of today's class. And then you have the correction of the respective conditions has to be done after you have found out exactly what the diagnosis is. Anything anybody wants to add? Abdul, you want to add anything to this?
No, sir, nothing.
How did you think Nikita did in this class?
He did well, sir. Like in the sense, it was concise, the presentation.
Yeah.
Metabolic acidosis, all that, whether it is compensatory, non-compensatory, it keeps going ahead. But I think for basic knowledge, this is enough.
Sanya?
He did well, sir. Uh, I I thought this was enough. Like Abdul said, it's pretty concise and enough for us to interpret an ABC.
I think Nikita did well. She does seem to understand the basics, but I think a little bit of elaboration of these things would have been better. But I think this is a learning process is a work in progress. So you have to continue to improve.
Yes.
Okay, good.
Okay, sir.
Good night.
Thank you, sir.
Good night.
Good night.